My name is Casey Hummer, and this is my VR medical imaging case review study. Our patient was a 36-year-old male who was brought in by ambulance 30 minutes after the onset of crushing chest pain with radiation to the jaw and neck. His associated symptoms included shortness of breath, nausea, lightheadedness, and increased anxiety. The patient also endorsed a 13-pack-year smoking history, heavy alcohol use, and frequent marijuana consumption. He reported several months of progressive chest pain and shortness of breath with exertion. He had no other prior medical or surgical history and does not take any medications regularly. However, the patient reports that he does not see a PCP. On exam, the patient was found to be lying uncomfortably in his hospital bed. He was diaphoretic and appeared older than stated age. His heart sounds were normal with a regular rate and rhythm. The patient was normotensive but tachypnic. For labs and workup, his EKG had significant ST elevation in the lateral leads and ST depression in the anterior and inferior leads. His peak troponin reached 31, and then cardiac angiography demonstrated a 70% occlusion of the proximal LAD. So let's take a moment to talk about what cardiac angiography or CTA scans are. If we look at our image here, this is a CTA scan. In this, contrast is injected, and then the imaging is timed for the contrast to be in the portions that we are most interested in. So in this case, the arterial phase, where the contrast is moving through the coronary arteries. If we take a moment to look at the coronary arteries and their anatomy, we'll note that the aorta comes up here. You have the right aortic sinus, which gives rise to the right coronary artery. You also have the left aortic sinus, which gives rise to the left coronary artery. That further splits into the left anterior descending artery and the left circumflex, which wraps around the posterior aspect of the heart. Now, if we take a look at the arteries on this image is not taken from the patient in our case, and they all look rather healthy. You can look for any collateral vessels that have developed, indicating that there is obstruction of flow and the heart is compensating. You can also look for evidence of the left ventricular hypertrophy or other signs of muscle weakness on this imaging. And if we look, I don't see any large, obvious points of narrowing in these arteries. Now, a CTA has a couple ways of grading it. There's a TIMI grading scale, which moves from grade 0, which is complete occlusion, all the way to grade 3, which is full perfusion of the artery with normal flow rate. You also can talk about coronary artery disease, where the severity is based on the estimation of how much of the artery is narrowed. So for instance, on this moderate, you can see there's a small portion of narrowing there, versus the severe, where it's almost completely pinched off. Now, a clinical correlation between our CTA and the EKG is that the places where the EKG shows elevation or depression can actually clue us into which vessels are occluded. So for instance, in our patient, there was ST elevation in the anterior leads with reciprocal depression in the inferior leads, indicating a proximal LAD occlusion. So right about here. However, if it were the right coronary artery or the left circumflex that were occluded, we would expect to see a different pattern of wave changes on the EKG. Now, returning to our patient, he was diagnosed with an acute MI, secondary to coronary artery disease, with varying levels of occlusion of all 4 coronary arteries. His care course began in the ED with pain management and anticoagulation. He was then transferred by ambulance to a level 1 trauma center for higher care, specifically cath lab and probable stent placement. At the cath lab, angiography revealed 100% occlusion of the left anterior descending artery with concomitant 4-vessel disease. PCI was attempted, however, stent placement failed to fully restore blood flow, and so he was scheduled for a quadruple coronary artery bypass graft. He's currently in recovery in the cardiac ICU with anticipated discharge home with cardiac rehab in about a week. As a small learning point, major indications for CABG include significant stenosis of the left main trunk, so up here, significant stenosis, over 70% of the proximal LAD with concomitant 2 or 3 vessel disease. That's what our patient had in this case. Symptomatic 2 or 3 vessel disease, or disabling angina despite the maximal medical therapy. And that concludes my study. Thank you.